Welcome everyone to our continuing series of the Buncke Clinic Virtual Visiting Professors. This afternoon or evening or morning for our colleagues who are logging in from India, we have the distinct honor and pleasure to have basically a man who is a mentor to pretty much all of us at the Buncke Clinic, Dr. Rod Hentz. Dr. Rod Hentz is a professor of plastic surgery, orthopedic surgery, and hand surgery at Stanford, and has really been at Stanford for pretty much all of his career. Most of us at the Buncke Clinic are Stanford grads, and so all of us have learned directly and personally from Dr. Hentz, and we also try to pass on what we have learned from him to our trainees as well. So his legacy continues even outside of Stanford. Just to kind of summarize a very few of his many accomplishments, Dr. Hentz was the former chief of plastic surgery at Stanford. In fact, when I was a resident, he was chief for most of the years that I was there as a resident, which was obviously fantastic for me. Also the head of hand surgery at Stanford, and also the VA, where we did a lot of hand surgery cases. As we all know, he was a former president of the American Society for Surgery of the Hand, which obviously is a title that only a few have had. He's authored hundreds of peer-reviewed articles and book chapters, and he's authored multiple textbooks, and many of which I still use on a daily basis. Everything from his atlas, which he wrote with Dr. Chase, to his textbook on tetraplegia. That's also very useful. He is internationally renowned in pretty much every aspect of hand surgery, but in particular, tetraplegia, brachial plexus, peripheral nerve. He's done a lot of work on Dupuytren's. In fact, he was involved in the clinical trial for the XIAFLEX study. And so he basically, his career spans pretty much every aspect of hand surgery, including studying the biomechanics of the hand and detailed knowledge of the anatomy, obviously, and more. So with that, Dr. Hentz, welcome again. Thank you so much for being with us. We're really honored to have you. And I am going to give you control of the screen in just a second here. Give me 1 second. Okay, let me find you here. There we are. Okay, you should see a prompt now that you've been made the presenter. And at the bottom of the screen, if you press the screen icon, it should share your desktop with us. Perfect. I'm going to ask everyone to please keep your microphones off and also the webcams off, and I'll do that myself until after the talk is over, in which case we can start asking questions. Thank you, Dr. Hentz. Go ahead.
See if I can find my program.
No worries. I imagine you've been giving a lot of talks in this time of COVID.
Let's see if I can get out of that. Am I still there?
Yep.
Okay.
Yep, we see the PowerPoint.
How's that?
It looks like it's a presenter view.
Okay, let's go.
Is there? Yeah, if there's a way to, yeah, perfect. That's it. Excellent.
Okay. Well, thank you very much, Babak, for that introduction. That was the nicest introduction I've had since since the moderator of a meeting was absent and I had to introduce myself. So thank you very much. I'm going to spend a little while talking about upper extremity surgical rehabilitation for the tetraplegic patient. And this work comes from my activities at two places, primarily at the Palo Alto VA Hospital, where we had a spinal cord injury unit established many years ago, and an upper extremity clinic, and a team that had physiatrists, physical and occupational therapists, psychologists, and some surgeons. And we examined over the years, probably now almost 1,000 patients and operated on many. So my experience comes from primarily from this institution. So I'm going to talk a little bit about some philosophical issues, like who should have an operation and when, and how to make surgical decisions, and finally end up talking about, are we doing enough? A lot of what I've learned, I've compiled with my co-author, Dr. Caroline Leclerc, in this small textbook, which is available on YouTube, maybe, I don't know. It's no longer in print, but we're trying to get something done. If we look back at an early appraisal, it was not felt to be very beneficial by physiatrists, the people in charge of patients. And in fact, they had some reason to be skeptical because a lot of inappropriate surgery was performed early on in patients who had to walk on their hands. And the long-term consequence of this, particularly altered sensation and spasticity, resulted in a lot of surgical failures. Fusions broke down, tenodeses would stretch out, the fingers would become contracted and clawed. And we learned the hard way that tetraplegia is not polio, because a lot of the procedures that were developed for polio were tried in the tetraplegic patient. They just didn't work. And in fact, Ludwig Gutmann, who ran the Stokes Manville Center and who wrote the first comprehensive textbook, said that at most 7% of tetraplegia patients might benefit, so not many. So this led to a period of surgical pessimism, with a greater emphasis on the development of adaptive aids such as this so-called Rancho splint, the wrist-driven flexor hinge splint, which was employed when the patient was ready to try to start his rehab. And this worked very well for its desired purpose. You could translate about 75% of wrist extension power in this little mechanical parallelogram to finger power, and you can get quite a bit of opening. There were surgeons in other areas who were pioneering more surgical procedures, particularly Eduardo Zancoli in Buenos Aires, who in the late 1960s, early 1970s published his series of 67 patients. These were mostly patients who had good wrist extension and flexion, but not very good finger or thumb function. And in his experience, surgery was always preferred over splinting. And if you had a good surgical result, it helped the morale of the entire spinal cord center. He devised a couple of wonderful procedures, biceps rerouting to restore pronation. He also called our attention to the likelihood of finding extra muscles, what he called supernumerary muscles, that could be used for tendon transfers. And his procedures advocated two-stage reconstructions, reconstructing an opening or an extensor phase and then a closing or flexor phase. I consider the modern era to be the responsibility of Dr. Eric Moberg. And in 1978, he published his little textbook. In 1975 or 1977, when I first was on the faculty at Stanford, he came and spent time, and I spent time with him in Long Beach. And in 1982, I had the chance to spend a lot of time with him on a sabbatical. On that picture is my son at the time in 1982 with Eric Moberg on his sailboat. And Moberg felt that aside from the brain, the tetraplegic patient's most valuable asset are the upper limbs. And he developed a philosophy which we followed for many, many years. First and foremost, the hand is an organ for more than just gripping and feeling. For the tetraplegic patient, usually a male, and at that time, usually a young male, it was equally important for human contact, and the stiff, contracted hands of the past had to be avoided. Moberg's philosophy regarding timing was that you needed to wait until the patient was stable. And he defined stability in 3 ways. Neurologic stability, meaning that they've achieved stability in terms of recovery, which occurs much earlier than a year in most patients. But just as important is psychological stability, being able to cope with the fact that they're probably going to be in a wheelchair, and as they are forever. And social stability, meaning that they have a place to go. They're not stuck in a hospital for the rest of their lives. So he said this takes a lot of time, and he felt that it took at least a year, and he wouldn't operate until after a year on most patients. We have moved a little bit in terms of that, and for newer paragrams, and we frequently will perform surgery before 1 year, particularly if the patient is developing or has developed upper limb pathology that interferes with their rehabilitation, learning how to live their lives. And one of the most important of these is the lack of the pectoralis major in the presence of an active deltoid. And so if the deltoid recovers, but the pectoralis major doesn't recover to act as an antagonist, the arm stays persistently abducted at the shoulder. And this makes transfers and other things very difficult. And this clever solution, which we've only done a couple of times, involves shifting the pectoralis major more medial to counteract and act as a better antagonist, or sorry, shifting the anterior deltoid onto the clavicle to act as an antagonist so that you didn't have that persistently abducted shoulder. Even more common, particularly with spasticity in the upper limb, particularly spasticity of the elbow flexion contractures, is this flex posture. Patients lying in the bed for a long period of time with their elbows flexed will develop elbow flexion contractures. And because the biceps is a supinator, they will develop persistently supinated forearms. And this really interferes with the ability for the patients to learn how to transfer and perform activities of daily living. Their potential treatments include Botox and chemical block of the musculocutaneous nerve or open crush of that nerve, which we've done a few times. Because if you crush the nerve, the muscle gets paralyzed, but it will almost always recover to nearly 100% within weeks or months. And during that time, the therapist can work on stretching out the elbow or doing serial casting so you're not working against a spastic elbow flexor. And in many, we did surgical release of the elbow contracture. This corollary of the contracted elbow, the persistently supinated forearm, really interferes with key activities, for example, self-feeding. So here you see a patient, he has a persistently supinated forearm, and while he can get this spoon down into his food, when he tries to get it to his mouth, it all spills out. And Zancoli, as I mentioned, pioneered biceps rerouting. If the elbow or if the forearm is flexible, in other words, has good passive pronation and supination, or if the elbow is fixed in supination, then osteotomy of the forearm. And we've performed this biceps rerouting a number of times. The biceps, which is normally a supinator, as it's rerouted, becomes a pronator of the forearm. The precaution is that you must have an active supinator, or else you turn a persistently supinated forearm into a persistently pronated one. So one of the tests that we do if we're in doubt is to do a musculocutaneous block and then be sure that the patient is able to supinate with their supinator before performing this procedure. Boberg's philosophy at the time dealt with the most common injury pattern, and this was injury at the C5, C6 level. And he felt that for these patients, the key was obtaining or improving active elbow extension, and then, at least for one hand, a key grip. Bunnell and others had focused on trying to reconstruct, as they did for polio patients, a three-jaw chuck pinch or a tip-to-tip pinch. But Moberg recognized, as had others, that the key grip is far more useful in these patients, and it's in fact the grip that we use most of the times ourselves. So his goal was to restore elbow extension so the patient could reach overhead and perform other activities, and then at least for one hand, provide a key grip between the thumb and the side of the index finger. I just learned that my little movies, or some of them, are not going to work. I apologize for that. So the benefits of restoring elbow extension are many. The patient can reach overhead, they can reach up into the shelf and get the cereal box off, or into the freezer and get the beer can. It helps with arm control and stability. It extends the useful environment. For example, if your elbow is held contracted, you have a small environment. If you can fully extend your elbow, we calculated that this increases your environment by about 700%. And importantly, it's good for pressure relief, to prevent pressure sores, and to help transfer for in and out, and for wheelchair propulsion. And in fact, if you don't have a triceps, you can't push a wheelchair, a manual chair, up any kind of a slope or across a rug, for example. Moberg in 1975, in what I think is a real landmark article in the Journal of Bone and Joint Surgery, proposed this transferring the posterior part of the deltoid with some kind of interposition graft into the olecranon to substitute and restore triceps function. Their prerequisites were a strong posterior deltoid. You had to have a supple elbow, meaning you had to have good passive extension. And for many, many years, it was the most commonly performed procedure. Lots of modifications were developed and proposed, particularly for the interposition material with tendon grafts or fascia lata, or as the lower picture shows, turning up a strip of the insertion of the triceps so it meets the detached deltoid. We liked the fascia lata because we had used it for many different things, and so it was always there. So for many of our patients, we would harvest a strip of fascia lata, detach the posterior part of the deltoid, turn the fascia lata into a funnel, and wrap that around the insertion, or rather the raised origin of the deltoid, and then pass this subcutaneously and weave the fascia lata through the end of the olecranon and tension it to provide elbow extension. And this is pictured here with the incision. As you see, the deltoid is exposed. There's an easy plane between the deltoid and the triceps posteriorly. You can bring your finger out about the middle of the deltoid and then detach it, taking as much fascial insertion as you can to help hold sutures. And this is our fascia lata strip. And you can see it's intubulated to wrap around the deltoid, and then it's going to be passed subcutaneously with a drill hole through the olecranon, and then it's passed in tension, and then the patient is put in a plaster cast for a few weeks, and then into a programmable or an adjustable elbow extension brace for a number of weeks while they practice elbow extension, preventing too early elbow flexion. And again, this is a video that was supposed to work, but this is a patient that we did bilateral deltoid to triceps transfers about 10 years before. And the video, if it showed, would show him being able to extend fully and control his elbows in a great manner. Our French colleagues showed us this technique using a Dacron graft to avoid harvesting tissue. This is performed in the prone position with the same mobilization of the deltoid as you see there. And this is the graft. It was actually developed by Jacques Tessier of Montpellier. And I learned it from him and his French colleagues. And it looks a lot like that fascia lata sleeve that I showed earlier, with the end wrapped around the deltoid and then the strips pass subcutaneously. And as you see here, woven into the triceps tendon or into the olecranon. And here's a patient. He's had this done bilaterally.
Down. And can you do it very quick as we did before? He understands everything.
So he's about a year post-surgery. A second procedure, which we more recently have performed, I think more often than deltoid to triceps, is biceps to triceps, is particularly indicated if the deltoid is weak. And we started using it primarily in patients who had a contracted elbow and were going to need surgical release of the elbow contracture. That surgical release always involved releasing the biceps or lengthening it. And so we decided at the time of surgical release of the contracted elbow, we would transfer the biceps to the triceps to try to gain extension, but more importantly, to remove a deforming force. This has now become a popular procedure with us, and perhaps in many areas it's done more commonly than deltoid to triceps because it's a simpler surgery and it can be done as an outpatient. In this case, the biceps is detached and it's routed medially around the medial side of the elbow. Why the medial side? Well, in almost all these patients, the ulnar nerve is not functioning and you're not going to put it at risk. Some have transferred this around the radial side and to their chagrin have injured the functioning radial nerve. So now almost everyone transfers this around the medial side where it's attached either into the tendon of the triceps or if you can get it long enough into the olecranon. And this is a diagram of the procedure. The incision, as you see, the routing subcutaneously around the medial side and attachment. And the postoperative regimen is about the same, casting for a period of time, maybe 2 to 3 weeks, and then into braces that can be adjusted.
Come down and touch your head.
This patient has had bilateral procedures, even in the hospital to have a hand procedure done.
Back down again and up.
So he's had bilateral biceps to triceps transfers.
And down to your head again. Okay. How fast can you do it? As fast as you can. Okay, very good.
You have to consider that the biceps is an antagonist as extension to the triceps. So how can it work? Well, in fact, we learned from Zancoli that if you stress simultaneous forearm supination, which the biceps is a primary supinator, and elbow extension, most patients can learn very quickly how to trigger this muscle without also firing their brachialis or their brachioradialis. Sometimes EMG feedback can be helpful to help the patient learn this task, but most pick this up very fast. We looked at 21 patients more than 10 years following surgery. 15 had deltoid to triceps transfer. 9 of the 15 were now able to use a manual chair most of the time, whereas before they needed a power chair. And a small but significant percentage were now able to self-transfer, meaning they didn't need anybody to help them move from bed to chair or chair to toilet and so forth. 6 of these patients, now 10 years after surgery, had biceps to triceps. All of these had had a contracted elbow. 3 of the 6 could use a manual chair, and most importantly, there were no recurrences of elbow contractures. Moberg also championed with a number of other colleagues a different way to classify patients. He didn't feel that the Asia classification was helpful for surgeons, so he and others introduced this so-called international classification. And it's very simple. You just count up the number of MRC grade 4 or 5 muscles distal to the elbow, and you come up with this classification. Why grade 4? Well, you can transfer a grade 4 muscle with the expectation that it will be able to do work. But a grade 3 muscle may lose power and can no longer do work. So it's a pretty simple classification, and because of the metameric scheme of the spinal cord, it usually works out so that international classification 1 is the brachyradialis. The next muscle innervated is usually the ECRL. And so if that were functioning, you would have 2 muscles, and that's an EIC2, and so forth as you see down the list. We'll keep this classification in mind because we'll use it to discuss various things. Now, in patients that don't have any muscles useful for transfer, there are few surgical options. In a few patients, we have arthrodesed the wrist, which allowed them to move from a splint that somebody else had to put on to one that they could put on themselves. It simplified splint use. Brummer in Finland described this so-called winch procedure where the flexor pollicis longus is attached to the ulna in such a way that with supination under the control of the biceps, the thumb is pulled against the side of the finger. We've never done this procedure and it's not been publicized much, but it is in the literature. For patients that are candidates for transfer, for example, international classification group 1, this is a patient that has a strong brachyradialis. And in this patient, we've typically transferred this muscle into the extensor carpi radialis brevis, not the longest, but the brevis, because it has a better moment arm for wrist extension. Because we wanted to restore at least a 3+ grade active wrist extension. If we could achieve this, then these patients were candidates for a grip either with an orthosis, as you see on the left, or the procedure that Moberg described in that same 1975 article, tenadesing the flexor pollicis longus to the radius, so that with wrist extension, the patient had an improved tenadesis effect with the thumb pressing against the side of the index finger. For the patient that now has 2 muscles, in this case, you don't need the brachyradialis unless the ECRL is weak. If the ECRL is weak, we'll go ahead and transfer the brachyradialis into the ECRB to provide strong wrist extension, because we think that that is the most important function that you can gain, because then you can perform various things for pinch, particularly the Moberg key pinch procedure. And this involves stabilization of the interphalangeal joint of the thumb, and then tenadesis of the flexor pollicis longus to the radius. Moberg recommended opening the A1 pulley to get the flexor to take a straighter line and bowstring a bit to provide better thumb flexion. And since that 1975 article, there have been many, many modifications of this procedure. This requires the patient having to learn to roll the fingers to provide a platform for the thumb. So there is some learning involved. And in patients who have a very natural tenadesis, then this is easy. If they don't, then they have to learn some techniques to help them roll this. This is a procedure that we performed most often in our early experience, because it was very predictable. And according to Moberg's philosophy, we could undo the procedure if the patient said, Well, I'm actually not any better, I'm worse. So we could undo the procedure and return the patient to his preoperative state, not risking any function. Some of the procedures led to what we felt were suboptimal results, particularly in patients who had a lot of natural MP flexion, because the flexion of the thumb would be excessive at the MP joint, and sometimes that caused the thumb tip to slip off the index finger. Paul Brand recognized this, and he suggested this modification of Moberg's key pinch procedure in patients where the MP joint flexes beyond 45 degrees. And you can see it's a routing of the flexor pollicis longus under the flexor tendons and then back through Guillon's canal onto the radius, so that the vector of pull is different. And he leaves the A1 pulley intact so that the MP joint of the thumb doesn't develop hyperflexion. We've used this modification. We found that the results weren't as strong as when we passed the transfer directly to the radius. We also devised several modifications, including performing Zancoli's lasso procedure using the paralyzed FDS to the index or the middle finger to try to help positioning those fingers for contact with the thumb. And we would tenodese the EPL and the EPB to the proximal phalanx of the thumb, particularly in patients that had a lot of flexibility of the MP joint, to try to avoid that very flexed MP. And this was a very predictable procedure, very appreciated by the patients. They were able to do many, many tasks. And this was our greatest experience in our early years. We changed our philosophy over time for these patients toward favoring an active pinch over a tenodesis pinch. And we would transfer the brachioradialis to the flexor pollicis longus to try to achieve an active pinch rather than one that depended on wrist extension or tenodesis. And this was also true, particularly for the patients in the so-called IC group 3. And these are patients now that have very strong wrist extension, and the brachioradialis can be used for various tasks. For these patients, we would frequently tenodese the extensor pollicis longus to the radius, so that when the wrist flexed by gravity, the thumb would open. If the CMC joint was very unstable, we would fuse the CMC joint to pre-position the thumb for pinch, and then transfer the brachioradialis to the flexor pollicis longus for active pinch. And again, I'm sorry this video isn't going to work, but you can see this is a patient who's had this procedure done, and he has a very adaptable pinch because he now has a muscle controlling it as opposed to depending on wrist extension. Our experience over the last years has been frequently in groups that have more resources available, group 4 and group 5. These are patients who have the brachioradialis, 2 radial wrist extensors, and the pronator teres, or the pronator teres and the flexor carpi radialis. And our goal in these patients has been more aggressive, and that is to achieve grasp and release, frequently in 2 stages. And we felt that these were patients that you could take a little bit of risk on because they had so much to gain. And so we would do several operations. Stage 1 was usually an opening phase carried out by tenodesis or transfers on the extensor side, followed sometime later after rehabilitation from the first stage with the closing or flexor phase carried out with multiple tendon transfers. And we've modified these procedures over the years, as I'll talk about in a moment. Typically, the extensor phase involved tenodesis of the common digital extensors and the extensor pollicis longus to the radius, so that when the wrist flexed, the fingers and thumb would extend. Again, if the carpometacarpal joint of the thumb was very lax, has lost all its ligamentous support, we would arthrodese that. If it didn't, we'd leave it alone. And we would frequently perform a Zancoli lasso to try to provide some intrinsic substitution at this first phase. We have modified this procedure over time. Later on, after that healed, we'd come back and do the flexor phase. And typically we would transfer the brachyradialis to the flexor pollicis longus. And we would transfer the extensor carpi radialis longus to the flexor digitorum profundus. We've learned the advisability of reversing the normal flexor cascade. Normally, our little finger is flexed more than our index finger. We learned that in the tetraplegic patient, that frequently led to the little finger coming down and contacting the object and no power left on the thumb side, on the index and middle finger side. So we reversed the cascade so that the greater power is now to the index and middle finger. Our later modifications, which we now perform and have had our best results, involve doing that lasso procedure at the first phase, but not tensioning it, just attaching the FDS to the A1 or proximal A2 pulley. At the flexor phase, we take the pronator teres and we attach that to the combined FDS so that we now have an active lasso. We have an active muscle performing MP flexion, and we've achieved a much stronger grip and better opening by doing this. So here are several patients with this procedure. With the opening phase, you can see how well they open their hand, their various grasps, as you see. This is a patient that's undergone this two-stage procedure with a very nice opening and a very nice grip. We looked at 18 patients in this category, groups 4 and 5, after 10 years. And we found that all of these had maintained their 1-year postoperative grip and pinch strength to within plus or minus 10%. So these didn't deteriorate over time. In this group, the pinch strength averaged 34 newtons, and we learned that intrinsic reconstruction improves the outcome both in opening and the ability to grip. A smaller number of patients have many more resources, and these would be OCU 6 and 7, and these are patients that have digital extension or digital and thumb extension and just lack finger flexion. In these patients, you can perform a one-stage procedure doing tendon transfers to provide thumb and finger flexion, and also the ability to position the thumb a little better so that they can have a more adaptable pinch, as you see in these patients. So this is a one-stage reconstruction, and for the thumb, they have flexion and abduction tendon transfers and anti-claw procedures. So it's mainly restoration of intrinsic function. And you can see this patient has minimal clawing on opening, and he has good thumb position, not just a key pinch, but he has an adaptable pinch that he can control. And again, this video, I'm sorry, won't work, but it shows a patient who's had 2 different procedures on one side versus the other, but bilateral hand reconstruction. He returned to work as an engineer, worked at Hewlett-Packard. He was totally independent. He now lives in Napa, again, totally independent. So we looked at a few of these patients because there aren't very many, and you can see that their pinch strength average 42 newtons, demonstrating again that the stronger they start out, the stronger is their function afterwards. And finally, very few patients, such as the patient who has finger flexion and maybe thumb flexion, they can be treated like combined peripheral nerve injuries with intrinsic reconstruction. Very few of these patients accept surgery because they're already functioning so well. Let's talk about some alternatives to tendon transfers in tetraplegic patients, because this has become a popular source of discussion. What other means are available? And so today, nerve transfers, in addition or rather than tendon transfers, are proposed for spinal cord patients. These procedures were proposed for spinal cord patients in 2009, 2010, particularly by Jaime Bertelli from Brazil. And this was one of his early papers, transferring the supinator to the PIN, the posterior osseous, to reconstruct thumb and finger extension. This was a case report. Many authors over the ensuing years have proposed many other transfers and have carried out these procedures and published them. For example, to restore elbow extension rather than tendon transfers, such as deltoid to triceps or biceps to triceps, transfer of the nerve to the teres minor and or the posterior branch to the deltoid into the triceps. For wrist extension, transfer of the brachioradialis branch to the ECRB has been proposed. For finger extension, supinator to PIN. And for finger and thumb flexion, transfer of the nerve of the brachialis or the nerve to the extensor carpi radialis brevis into the anterior interosseous nerve to try to restore some FDS and FPL function. And these have all been proposed and have their champions. I've had many concerns over the years, and for these reasons. Many of the reports are single cases or just small case series. And for most, there's no long-term follow-up. Generally, it's 1 year or maybe slightly more. And I've been concerned that many of the authors of these papers are what I consider nerve surgeons and with little experience, at least in terms of publications, in treating tetraplegic patients. So I'm worried about that background and also their seeming bias for nerve transfers in lieu of or in place of tendon transfers. So I started looking more carefully at the literature and at the results, looking into the papers. So let's consider the evidence. Here's this paper from Bertelli and Gazzoni in 2015. They reported 13 limbs in 7 patients, 19 months post-op. They transferred the supinator to the PIN, and they got great looking results in terms of MRC categories. Thumb extension was MRC 4 and 8 and 3 and 4, and that's a very good result. Finger extension was MRC in 12 of 13 hands. So PIN, supinator to PIN appeared to be very predictable. But if you look closely at their paper, almost 50% of these patients had to have radio-ulnar fusions secondary to inadvertent supination during extension. In other words, when they tried to use it, they would supinate, and that's not a very functional position for acquiring objects. We usually acquire objects by reaching for them in pronation. So about 50% of these patients required a secondary operation, which to me spoke to maybe these folks not having sort of the biomechanical experience to predict that this might happen. Another paper from Bertelli, this is from 2017. These were 17 upper limbs in 9 patients. The goal here was to restore grasp and pinch. And the procedures that were performed were the brachialis to the anterior osseous in 8, the brachioradialis, the brachioradialis to AIN in 4, and the nerve to the ECRB to the AIN in 5. And the results, as you see here, 4 of 8 had an M3 and 1 had an M4. And you say, well, to me, an M3 grasp is a failure because M3 really can't do much work. It may close the hand and look good on a video, but if you're asking it to hold on to a heavy object, it's not going to work. So I consider the brachialis to AIN, these 8 patients, 7 of 8 in my estimation are failures. And the brachialis or the brachioradialis to the AIN in 4 of the patients, 1 patient got M4. So in this group, in my estimate, 3 of the 4 are failures. Now the ECRB to AIN did work, and these all worked. So great. But if you take the nerve to the brachioradialis, it's no longer available as a tendon transfer if your operation fails. And now you want to do a tendon transfer to restore pinch. Well, you've taken the nerve supply to the number 1 performer, and that's the brachioradialis. The ECRB is the prime wrist extensor. And so as someone interested in biomechanics, I have to ask myself, is that proper? Is it proper to take the principal wrist extensor and use that as the source of a nerve transfer? More recently, Natasha Van Ziel in Lancet at the end of last year published her results, and in a very good paper. And if we look closely at this, we see in her paper that 22 patients participated and had their limbs studied. 14 of the patients had nerve transfer only for grasp and pinch, usually a transfer to the AIN. And of these, 9 of them were brachialis to AIN, and 5 were ECRB to AIN. And then 8 patients had tendon transfers. In that first column where I've put the little blue squares, this is their grasp at 12 months. And you can see of the 14 patients that had nerve transfers, their grasp at 12 months was less than 1 kilogram, whereas the tendon transfers had almost 4 times the power. Now, if you wait another year, these patients' grasp after nerve transfers improves, but it's taken now 2 years for them to achieve a decent grasp, whereas the patients who had tendon transfers probably achieved a decent grasp within 6 months of the procedure. She presented her results for restoring elbow extension using nerve transfers, either the teres minor and or the posterior branch of the axillary to several triceps branch. And she reported the results in 16 limbs, 2 of which achieved an MRC score of 4, meaning they could work against gravity and some resistance. 6 of the 16 could extend against gravity, but not against very much resistance. And then 4 achieved a grade 2, and 2 had nothing, and 2 were lost to follow-up. So I look at this data, and for me, these last 8 patients are failures. So I'm still a skeptic about performing nerve transfers in place of tendon transfers, and I'm more toward performing nerve transfers and tendon transfers, but still favoring tendon transfers where you want work. So my preference now, for the weaker patients, these IC 1 or 2 with very few resources, I'm reluctant to use the brachialis nerve in case I need the biceps to restore elbow extension. Because if the brachialis is gone, then you can't use the biceps. I'm reluctant to use the supinator to PIN in these patients unless I can figure out some way to restore finger and thumb flexion, because if you restore finger and thumb extension, they will stay in an extended posture and they will lose their natural tenodesis effect of wrist extension and finger flexion. And in these patients, there are not many good ways to achieve finger and thumb flexion, excuse me. However, because supinator to PIN appears to work in those patients that have preserved pronator. In other words, you can transfer the supinator and they're not going to develop this supination difficulty that Bertelli experienced because they have a pronator and they have a potential for pinch and grasp. I think it's very reasonable to do a supinator to PIN transfer, particularly during their early rehab, because this sets them back just a few days while they recover from this soft tissue procedure, and then they can go on with their rehab. And then at a later date, at the appropriate time, I favor standard tendon transfers. Finally, are we doing enough surgery? Suppose the statistics are that there are 5,000 new cervical spine injuries in the United States, and perhaps 50% of these would benefit from surgery, which would mean there ought to be about 2,500 cases per year. This is work from my colleague, Dr. Catherine Curtin. However, if we look at statistics that were available when she was starting this study, we can see the total national experience is very far from this number. So she asked, why are these procedures underutilized? Well, do they work? Maybe they're not utilized because they don't work. She reviewed the literature and found a number of articles that met their inclusion criteria and found that elbow extension was a good procedure. They average more than grade 3 with a 25% complication rate and not particularly serious complications. For pinch reconstruction, these patients average almost 2 kilograms of pinch. That's about 5 pounds or more. And with 5 pounds of pinch, you and I can do about 85% of all the activities of daily living. So these procedures appeared to work. They were effective. And 90% of the patients that were polled were satisfied with the procedure, and the risk-benefit ratio is acceptable. I'm sorry this slide didn't turn out, but it asked what these patients value, and they valued most upper extremity reconstruction over walking or bowel or bladder function or even sexual function. So they were interested in this, but only 25% said they were strongly interested in surgery. So the question is why? Many potential patients are simply not informed during their rehabilitation, and physician counseling can result in a negative perception. If the physician is negative, if the physiatrist or the rehab specialist are negative about surgery, they will project this perception on the patients. And a national survey showed that physiatrists had reservations about upper extremity reconstruction, but those that had a more positive perception wanted to refer patients more often. So Curtin's recommendations were that we need a systemic change, and perhaps this involves incorporating hand surgeons in multidisciplinary spinal cord teams and training spinal cord physicians regarding integrating those of us that like to do this into their network. So it appears that it's the primary physician that's key to improving the utilization of these procedures, and education and cooperation is the key. So for me, doing this surgery in our tetraplegic patients has been the most personally rewarding surgery that I perform, and more hand surgeons should look at the opportunity to become involved. And that's the end. Thank you. So Babak, you can take control again.
Dr. Hentz, thanks again. Really an amazing talk. And I think for those of us who trained with you, we did a fair number of these operations. But I can tell you that it's pretty rare in most programs to get even a little bit of tetraplegia reconstruction. I think for the reasons that you mentioned, in that there are simply not, I think, enough surgeons who are well versed in it. And because of that, the potential referral sources don't really think of it or potentially discourage the patients from seeking these surgeries out. So I think I would certainly agree with you. So have you noticed a trend at all in the last, let's say, decade or so in the number of operations going down? I'm wondering if there's kind of a temporal change over time with the popularity or the, I guess, comfort level of hand surgeons graduating programs nowadays with these techniques.
Well, there are a number of changes. When I started, excuse me, when I started doing this work, most of our patients were young, risk-taking males who crashed their motorcycle or their car or dove into the shallow pool or this kind of thing. Or today, a lot of our spinal cord patients are much, much older. They are patients who have fallen and have cervical spinal stenosis and developed tetraplegia. And many of these patients are incomplete tetraplegics with lots of spasticity and not very good candidates for traditional muscle tendon transfers. So our demographics have certainly changed, and I think this is true everywhere. Our surgical experience has gone up and down a little bit, as you alluded to, according to whether there is a local champion in the spinal cord unit who sees value in this and helps us identify patients and sort of lays the groundwork. I think over the country, from what I understand from Dr. Curtin, the indications and the numbers are relatively stable. They're not going up, not going down.
Interesting. I'm going to open up the forum to any questions from the audience. Feel free to turn your mic on to ask any questions. In the meantime, I'm going to ask a technical question regarding tendon transfers in general. When I was a resident, I remember that you were doing sarcomere length testing to try to identify potentially the optimal tension, if you will, of a tendon transfer. And I think most of us in practice would agree that if the transfer is too loose, you can't really tighten it. If it's too tight, you can usually loosen it a little bit with therapy. Can you update us on your kind of thought process when you're doing active tendon transfers of how you like to set your tension with regards to the force tension curve of the muscle?
I'm frequently asked that question by the resident of the fellow, and my answer is just right. The study that you alluded to involved several centers around the country with a device that let us measure the tension of the muscle before transfer and the tension of the muscle afterwards using a device that measured the sarcomere. And we did that study, and we learned that in spite of the great difference in how various surgeons position the elbow or position the wrist or position the thumb or the fingers or judge what was tight enough, when we did the sarcomere measurements, turns out that everybody did it about the same, which told us that the surgeon has a pretty good notion of what's about right. And that probably comes from experience. But it told us that the surgeon's experience was more than enough to help judge what was the right tension.
Got it. Any questions from the audience? I want to open it up to see if anyone has any questions. Danny, do you have a question? I see your mic's on.
Dr. Hentz, thanks so much for sharing your experience with us. Question regarding the approach to patients and their spinal cord injuries and the decision about whether to proceed with these procedures to improve function. In other words, my question is, what is your approach if a patient, how quickly will you move towards performing these types of procedures to rehabilitate them? And how much time? I recognize that there's a balance between wanting to get these done before contractures and passive motions lost, but wanting to wait long enough to see what sort of recovery you might get naturally. And so my question for you is, how do you decide when's the right time to proceed?
If we have a chance to see patients early and work with therapists, I think in general you can usually prevent with good therapy the contractures that we saw before. And if we can't, then those are patients that we'll offer some of these early surgeries, although our physiatrists are getting much better with Botox and those kinds of things. So we don't do quite as many corrective procedures to help with the rehabilitation. We still wait until that period of stability, although now with the patients that I mentioned earlier, we will approach them with the concept of an early nerve transfer because it doesn't set them back. It can be done while they're doing their in-hospital, initial rehabilitation. So we're doing more of these. For the patients that aren't candidates for that, we talk with them. We have our clinic. We meet with them. We now see every new patient, every new tetraplegic patient that comes to the unit. We have a group of former patients that are willing to talk with these patients, and I think that's been a very important key, is finding a patient that's had a result, because patient-to-patient communication is there's nothing like it. And then we have some films that we show patients, and then we let them decide.
Thank you.
Glenn Gaston, I see your mic is turned on. Do you have a question for Dr. Hentz?
Yeah, thanks, Rod. Great talk. And we're excited we matched one of your residents to come join us for fellowship today. So we're looking forward to having a West Coaster come out to Charlotte. But one question, you didn't mention much on split FPL transfer to EPL to concomitant with like a BR to FPL transfer, like Van Hees has done to balance the IP joint. Any role for that in your practice?
Absolutely. I'm sorry I meant to mention that, because that has been a game changer for us. So this is procedure described by Mohammed and Rothwell from New Zealand years ago. We refer to it as the split New Zealand transfer, but we use that uniformly on essentially any patient that's getting any kind of transfer for thumb flexion. If we're restoring thumb flexion, we'll do this split transfer to try to create a yoke or a check rein across the IP joint of the thumb, so that all the force now is at the MP and the CMC joint. So I've now used this routinely in my ulnar nerve palsy patients where I'm trying to restore thumb function or thumb strength. So it's been a wonderful addition.
Greg Buncke, I see your mic is turned on. Do you have a question or comment for Dr. Hentz?
Hey, Rod, thank you so much for the talk. It's wonderful to hear your long-term experience. That's really helpful for all of us. I just wondered if, we have had so much trouble getting physiatrists and to get on the bandwagon for surgery for these patients. I think you've had such a wonderful relationship with them, and we've seen that through the years. I mean, it seems like Catherine's on the right idea of trying to get something systematically, but it seems like it has to happen at the early educational level for physiatrists. I mean, is there any way to get on their curriculum early on? It seems like there's a lot of old school that doesn't want surgery done.
Well, you're absolutely right. I think in terms of entry-level information, there's a specialty, a certificate of added qualification or something like that in spinal cord for physiatrists, where they go and take an exam. And I think they also have courses, kind of preparation courses like we have. And to me, that's the ideal time. And if you can get on the program for the people that are sitting there, preparing for their boards, if you will, or their certificates, I think that's the ideal thing. And I think trying to get on programs at their meetings. We can send articles into the Journal of Hand Surgery, but that's not going to reach any physiatrists. And I think if you want to help, you have to try to publish in literature that they read.
I mean, do you give lectures to the physiatrists at Stanford ever?
Yeah, routinely.
Yeah,
we're part of their curriculum, and one or the other of us gives a talk every year to the residents, part of their didactics.
I think that's great.
Yeah.
I will say this: it took 20. They have a spinal cord unit down the road at the Santa Clara Valley Medical Center in San Jose, about 25 miles from us. And I went down there and gave a talk, and I bet I went down there for 15 years before I finally got invited to examine a patient, and then started operating on patients. So, you have to have the long-term look.
Right.
And I remember you coming down and operating at the Valley when I was a resident there, so it definitely paid off.
Took a long time to get in the door.
Well, I think your patients are obviously very lucky to have you, because I think you've really put a lot of these operations on the map here in the U.S. So thank you for that. With that, Dr. Hentz, I wanted to thank you again for being with us tonight and educating us. It's always great to hear your tremendous experience in this field, and we look forward to having you again, hopefully soon. So thanks again for joining us. Appreciate that.
Thanks, Babak, and thanks for the Bunkies for inviting me. Thank you again.
Great, thank you. And our next talk, for those interested, tomorrow morning at 7 a.m. Pacific time, Dr. Eyal Gur of Tel Aviv will be discussing his experience with reconstruction of the paralyzed face. So we hope to see you then. Thanks, everyone. Take care.
Thank you.